my teachers, my senior colleagues and colleagues. My name is Dr. Esther Okobeni, and I welcome you all to this week psychotherapy study group weekly event. I'll be speaking on common factors in psychotherapy. This outline will guide us through the presentation. We'll take a quick look at introduction and definitions. We'll look at common factors in psychotherapy, contextual model of common factors, and then conclude. Start by asking the question, does psychotherapy work? The literature says yes, and it says that 40 to 70% of clients who receive psychotherapy show substantial benefits, and that at the end of psychotherapy, the average treated person is better off than the average untreated. We have agreed that psychotherapy works, and now if it works, what makes it work? Is it the model of psychotherapy? Is it the techniques being used? Studies again show that models account for a small amount of the variance in psychotherapy outcomes. Virtually all psychotherapy models and techniques are effective with some people some of the time, meaning that sometimes it may not work and sometimes in some people it may not be effective. So differences in outcome between models is consistently small or negligible. Outcome differences between therapists using the same model have been found to be 2 to 3 times greater than the differences between models. So it is more of the characteristics, the qualities, the uniqueness of the therapist. And this is one of the common factors in psychotherapy. So it's in other words saying that the common factors may be more relevant to the outcomes of psychotherapy. These are findings from a meta-analysis trying to see the factors that are associated with psychotherapy outcome. This study found that this is a study of studies. So this study found that extra therapeutic factors accounted for 40% of therapy success, while therapeutic alliance, or what we may refer to as therapeutic relationship, accounts for 30% of therapy success. Therapy model of technique, that is the type of therapy, only accounted for 15%, which was similar to the placebo effect, because the placebo effect also accounted for 15%. We can say that the common factors
Sorry, I hope everyone can hear the recording. Thank you.
of extra therapeutic factors and therapeutic alliance are more relevant in determining the outcome of psychotherapy rather than the specific type of psychotherapy being offered. Still on introduction definitions. Common factors in psychotherapy are the non-specific elements shared by different psychotherapies that contribute significantly to positive therapeutic change. Despite the diversity of therapeutic approaches, whether it is CBT, it is psychodynamic therapy, it is humanistic therapy, or any other therapy, research has shown that there are common factors across all forms of therapy that contribute significantly to treatment outcomes. These common factors were first discussed in a seminal article by X. Rosenwig in 1936 and popularized by J. Frank in his book Persuasion and Healing. Now, a particular common factor model called the contextual model has been proposed. We'll look at this in details later. Many of the common factors are not theoretically or empirically distinct. They complement each other, they are intertwined. It's kind of they are similar in a way, related to one another in a way. So, for example, therapeutic alliance, we talk about empathy. Then empathy stands on its own as a common factor, and therapist characteristics just talks about empathy. So they are kind of intertwined. So the entire common factors movement is about the human and relational core of effective psychotherapy. You will get to know that these common factors are the normal attributes of day-to-day interactions that tend to enhance human relationships. So the work on common factors does not support any specific form of therapy over another, and it's not even supporting humanistic therapy, even though we say they are human and relational in nature. So, what are the common factors? The truth is that there is no definitive list of common factors. The list in the clinical literature often differ. So you see all sorts of common factors, different authors talk about different common factors. But what I've listed here appear to be the most commonly used common factors or the most commonly talked about. Some other common factors are embedded in the ones I have listed. And so I'm going to talk in details about therapeutic relationships slash alliance, empathy and unconditional positive regards, expectancy and placebo effect, client factors slash extra therapeutic factors, therapist factors and techniques, and then I'll talk about cultural adaptation. First common factor I'll be talking about is therapeutic relationship slash alliance. Although these terms are often used interchangeably, there's a subtle difference between them. Therapeutic relationship refers to the broader connection between a therapist and a client, encompassing the emotional bond and the overall dynamics of therapy. While therapeutic alliance specifically denotes the collaborative working agreement between the therapist and the client. So therapeutic alliance tend to focus more on shared goals and tasks to achieve a positive change in therapy. So therapeutic alliance refers to the collaborative bond between the therapist and the clients. It's about the objective, the agreement on the objectives, the goals of the therapy, and the task, the activities that will be required in the therapy to achieve the goals. So the alliance is a key component within the broader therapeutic relationship, and this is often considered the most critical predictor of psychotherapy outcome. As a matter of fact, various mental analysis suggests that therapeutic alliance accounts for 30 to 40% of therapy success, making it more important than specific technique used for therapy. Still on therapeutic relationship alliance, we now look at the elements of a successful therapeutic relationship. The first element is trust and rapport. Some basic level of trust is fundamental to every therapeutic relationship. So even an initial bond between the patient and the therapist is very important. And so it is important throughout the process of therapy. The first meeting of the client and the therapist is essentially a meeting of two strangers. So while the therapist is evaluating the client is also making his or her own evaluation of the therapist. The client wants to know, oh, can this therapist be trusted with very important or very secretive information? Therapists have the expertise to handle my problems. Will this therapist be committed? Will it take the time and the effort to understand my problems and to know the context in which these problems are situated? So the client is concerned about confidentiality too and the ability to disclose difficult information without disrupting the social bond, the relationship between the client and the therapist. So a strong supportive connection where patients feel understood, feel comfortable and feel accepted is very important. Another element is the elements of empathy and understanding. We'll look at this in details very soon. And then the another element is the elements of agreement on goals and tasks in therapy. The truth is that psychotherapy is all about setting goals, it's all about achieving these goals via different tasks and activities. So the therapist and the client we have to share a common understanding and agree on therapy objectives. So clarity on the steps, the intervention and activities that will be used to achieve the goals will also need to be shared and agreed upon and understood by the clients. I've already talked about the impact of therapeutic alliance. So, therapeutic alliance is a strong predictor of therapy success, regardless of the modality that is being used. We'll look at the second common factor, empathy and unconditional positive regard. Researchers or research has consistently demonstrated that therapist empathy is one of the most potent predictors of client progress in psychotherapy. I mean, progress. I'm not just talking about outcome now. So, Rogers in 1951 and 1961 defined empathy as the ability to perceive accurately the internal frames of reference of others. This is not just the emotional experiences, also the cognitive processes of a client. It doesn't matter whether the cognition is looking unreasonable, is looking stupid, but the ability of the therapist to see things from the perspective of the client and understand is empathy. So the capacity to understand the experiences, the thoughts and feelings of another is empathy. Empathy is a basic relationship skill that is required to understand others at even the most basic level. On empathy and unconditional positive regards, in 1910, in 1990, Barrett Leonard posited a model of empathy as an active cyclical process characterized by three phases. empathic resonance, empathic communication, and perceived or received empathy. In empathic resonance, the therapist resonates to their clients' experiences using information from their own bodily reactions and inner experience to understand how their clients are feeling moment to moment and the significance and meaning of events to their client. I think for me, this is just saying put yourself in the patient's shoes so you can truly understand the experiences of your patient. And having understood, the therapist needs to communicate their understanding to their clients. A couple of days ago, I had a patient referred to me. She was in my office with her husband and she kept talking about her unpleasant experiences in her marriage for 24 years. She was bitter. And at a point I paused and I said, I understand exactly how you feel. I understand exactly what you've been through. And I also understand that because you've buckled up all of this for 24 years is the reason you have experienced what you're experiencing now. And she said, yes, that is it. That is what I've been waiting for my husband to say in 24 years. And then she broke down in tears because at this point, she felt understood. So the last phase is that the client should be able to now understand and feel understood and express that. Feel understood by the therapist and then express the fact that yes, I understand now. And that can be a whole lot of relief to the client. Like seeing in the client I just described, she felt better, she broke down in tears, knowing that for the first time in 24 years, someone is saying, I can feel you, I can understand you, I know what you've been through. Empathy and unconditional positive regards. Now, unconditional positive regard is vital for creating a safe and a supportive environment for therapy. The client should be valued and accepted for who they are. Positive regard refers to the therapist's attitude of complete acceptance, non judgmental, and support towards the client, regardless of what the client says or does. Our facial expression should not express condemnation for the client, irrespective of what they say. Unconditional positive regards requires the therapist to cultivate empathy, active listening, and a non judgmental stance. It gives the client a greater sense of self worth. It can be difficult sometimes to maintain this as therapists are also human and may have their own biases or reaction, but with experience, with personal growth and awareness, and the consciousness that we have to maintain unconditional positive regards, therapists can build the skills for unconditional positive regards in their therapeutic relationships. The third common factor is expectations and hope. Expectation for positive outcome. Now, clients often enter therapy with certain expectations about improvement. These expectations can create self-fulfilling prophecies. So they are looking forward to recovery, and that can actually influence a real change in the therapy. So clients who believe that therapy will help them are more likely to improve. So the therapist should instill hope by reinforcing the belief that change is possible. The placebo effect, for instance, in therapy accounts for about 15% of therapy outcome success in therapy. So merely engaging in a structured healing process can produce positive changes, even if there is no specific intervention offered. So research estimates that 15% have said that of therapy outcomes can be attributed to expectancy effects, highlighting the psychological power of belief. The fourth common factor is client factors and extra therapeutic factors. So these are personal and environmental factors that exist outside the therapy but can influence the outcome of therapy. The client factors are personal factors that may significantly affect therapy outcomes, and this list is not exhaustive, but I'll talk about these ones. The client's willingness to participate and engage in therapy can significantly impact outcomes. You can force a horse to the river. You cannot force it to drink water. So it may be the relation saying go for therapy, and the client has not even seen the needs for therapy. It may affect the outcome of therapy. Is the client well motivated for therapy? Why is the client seeking therapy? It's important to assess the level of motivation, the stage of readiness for change in the client. Is it in the pre-contemplation, the contemplation down to readiness to take action? So readiness to change is also very important. The personality traits of the client is important. You agree with me that it's difficult to offer psychotherapy to persons with narcissistic traits because they don't want to come down from their high horses. So they may not agree on goals, they may not agree on tasks with you. The past experience of the client is important, the previous experience with therapy or trauma will also influence the outcome of therapy and the participation in therapy. Values and beliefs are other client factors that can also affect how much they agree on with you on goals and how much they are ready to go with you with the activities and the task of therapy. About extra therapeutic factors. Extra therapeutic factors are also common factors and they refer to elements outside of therapy that influence a client progress, like their social support system or life events they may be experiencing or they probably would have experienced. So extra therapeutic factors could include a client family dynamics, it could be work stress, it could even be a positive life event that is creating issues and stress for the clients. It is important for the therapist to explore and address these factors to improve the outcome of therapy. Research suggests that extra therapeutic factors account for around 40% of therapy success, emphasizing the importance of a client personal and social context. These extra therapeutic factors might be the precipitating factors for why the client is seeking therapy. They may be the predisposing factors, they may be the maintaining factors for the condition or the illness for which the client is seeking therapy. So they have to be dealt with in most cases to get a positive result. Fifth common, the fifth common factor we are going to talk about is therapist factors and technique. We've talked about the importance of the therapist factor earlier in this presentation. The reason why two therapies will offer the same technique, the same CBT, the same mindfulness, and then you are getting different results is because of the factors that are unique to each therapist. So why the specific therapeutic model used is important, certain therapist qualities and behaviors consistently lead to better outcomes. For example, empathy. We've talked a lot about empathy. It is very important in the progress, empathy and positive regards in the progress made in therapy. Flexibility and adaptability is important, adjusting techniques based on client needs rather than the rigid adherence to a single approach. So you say, oh, I'm doing psychodynamic therapy, so you're not going to use and some specific techniques that may be helpful from other models. Even when you see that this patient needs to have some cognitive reframing to be able to move forward in your psychodynamic therapy, you say, no, I'm sticking to the technique I'm using. So it is very helpful to be flexible in therapy. Then the competence and the experience of the therapist is also very important. More skilled therapists tend to achieve better results. Congruence is another important element of the therapist factors. The therapist's verbal and non-verbal communication should align with internal thoughts and feelings. Remember, we said the client is also evaluating you, particularly when they are when they are releasing very difficult information that could be condemning. So if you are showing empathy, saying, okay, I can understand what you are going through, let your facial expression be congruent with that. You don't say one thing and then your face is your thought, because your thoughts can be expressed in your facial expression without your knowing. It's saying, look at this woman, how could you have done that? Oh, stupid woman. The client will notice that, and that can affect the progress, the ability of the client to open up in therapy. We're still on therapist factors and techniques. We'll now look at the elements of genuineness. Genuineness is very important, and it is a crucial common factor in psychotherapy. It refers to the therapist being authentic and transparent with the clients, presenting their true self without facade, which fosters trust and allows for deeper connection in the therapeutic relationship. So these are the ways you manifest or you show genuineness in therapy. Self-disclosure. Let the client know that you are human, you are prone to errors too. You are not supernatural. Appropriate self-disclosure can demonstrate authenticity, allowing the client to see the therapist as a real person. Another important element is active listening. As a matter of fact, active listening is relevant to all the common factors. It is so integral to therapeutic relationship and alliance, to empathy and unconditional positive regards. Active listening is very important in the client and in addressing, identifying the client factors and extra therapeutic factors. It is also very important in trying to explore the expectations of the client. So it is paying full attention to the client's words and to the client's emotions. It is reflecting and understanding the client without being judgmental. It is not passive listening. You are not paying full attention. You are listening, but you are picking a phone call. You are checking a message on your phone while the client is talking. No, that is not just disrespectful. It also gives the client the impression that you are not ready. You are not ready to commit to solving his or her problems. It is not combative listening, where you cannot even wait for the client to finish talking. You want to interject, or you make comments like, wow, you mean you did that? Oh no, I can't believe that. No, it is active listening that is not judgmental. The another element is acknowledging your limitation. This is very important. If a therapist is unsure about something, openly admit it instead of pretending to have all the answers. This demonstrates authenticity. There's nothing wrong with telling the client, okay, I think I'll look up on that and then we can discuss that in our next session. There's nothing wrong with telling the client that, okay, I'll discuss this with some of my colleagues so that we can have a common agreement on this. I mean, not necessarily discussing the details of the client issues, but the difficulties you're having. So it is important to let the client know. that you also have limitations when that arises. Still on therapist patterns and techniques. We've talked a lot about therapist patterns, so let's look at some techniques that have been found useful across different types of psychotherapy. So there are techniques specific to specific therapies, but they have their usefulness in various modalities of psychotherapy. The first one is cognitive reframing. This helps the client to shift their perspective on problems, to look at it in a different way, to reframe. Then behavioral activation encourages positive behaviors to improve mood in clients. So you can use this whether you are doing psychodynamics, you are doing interpersonal therapy. You can use behavioral activation, mindfulness and emotion regulations. It teaches the client to manage distressing emotions. Then exploration of past experiences. Remember, we talked about this one, talked about client factors. These are factors that can positively or negatively influence the outcome of therapy. So it's important to address unresolved trauma or conflicts when relevant. So you won't say because I'm doing CBT, this is not psychodynamic therapy. You are not going to look at unresolved conflicts or trauma, because if you don't resolve them, you really can move forward in in therapy. Then therapist factors and techniques. I think I mentioned this earlier, contributes about 15% to therapist success, and they are critical in sustaining engagement in therapy and guiding change in therapy. Now we are on the last common factor, cultural adaptation. Cultural adaptation emphasizes that the explanation given for the patient's distress and the therapy actions must be acceptable to the patient. Cultural adaptation is a therapist's ability to recognize, respect, and integrate a client's cultural background into treatments. It acknowledges that cultural factors influence a person's experiences, values, and responses to therapy. I'll give a case scenario at the end of this slide. Therapists need to be aware of cultural norms. They need to be aware of cultural of traditions. They need to be aware of the belief system that shape the client or the patient's worldview. Why are they looking at things the way they are looking at things? Why are they presenting the way they are presenting? What is their cultural background to all of this? Therapy should not impose their own cultural values on another or on the client, but instead they should adapt intervention to be culturally appropriate. This can be difficult to do, but it's something with experience one will get to be skillful in. So, evidence based treatment that are culturally adapted will be more effective for the cultural group for which the adapted treatment is designed. So, adaptation may be in language. Sometimes I notice that because I speak Asian and I work in an Asian community, many patients, particularly the women, the elderly who are not so literate, they want to say, I want to see madam, where's madam, where's madam, I want to see madam, because they want to speak Asian with me. So there should also be a cultural congruence between the therapist and the patient. Adaptation could be use of cultural rituals and explanation adapted to the needs of the client or the group of clients that you are dealing with. Now, I remember this particular patient that I had. She had had postpartum depression for 2 years with some panic attacks, and then she was always presenting to the accident and emergency because of the panic. And one day somebody referred her to see me, and then I started having some sessions with her. And then in one of the sessions, she came with her child, who was now 2 years old, a male child. And then she told me that the mother-in-law was responsible for what happened to her after she gave birth to her child. The mother-in-law did something that made blood to flow into her head, and that was what was responsible for what she was going through. And so, because of that, she had cut all ties, severe all ties with her mother-in-law. Her mother-in-law could no longer come to her house. She was no longer going to the mother-in-law's house. And the husband was not happy about the situation, and that was kind of causing some issues between her and the husband. So I allowed her to say everything she wanted to say. And again, I think she also said that it was a pastor who told her that the mother-in-law was responsible because she wasn't psychotic. The mother-in-law was responsible for her issues. So at the end, I had to agree on a task with her, which I felt was a cultural ritual. But before then, I had just posed a question to her and I said, okay, how would you feel? Your child is 2 years old now and is a male child. This child grows up, he gets married, and then the wife says you are a witch, does not allow you to enter your son's house and does not come to your house. And she said, God forbid. So it was something she did not want to relate with at all. And I said, okay, I didn't go beyond that, but I sold a seed for her to reflect on. And then I now said, I want you to agree with me on this task if you can. Christmas is around the corner. I want you to get your mother-in-law a gift this Christmas, something she can use for Christmas. Maybe a chicken, maybe a turkey, maybe a bag of fries, whatever you can afford. And then you go to her with your husband and this baby, and then give her the gift and ask her to pray for you. And she said, oh, fine, to pray for me, yes, I'll go. I'll do anything to be okay. And then I didn't see her for about 6 months. And then one day she came to my office. I could barely recognize her. She was looking so beautiful. She was looking so good. And she just went on her knees to say, Doctor, I want to say thank you. I want to say thank you. I did what you asked me to do and I have been okay since then. My mother-in-law was so happy. She prayed for me. She accepted the gift. And as I speak to you, I have not been taking my fluoxetine. And she said, how did you even know that was going to work? I laughed and I said, well, I'm the psychiatrist. So this is 3 years after. She's still off medications. She's off therapy session and she's still doing very well. So sometimes we may have to look at what is acceptable within the culture or the participants to resolve some issues. And for me, I felt that was a form of cultural rituals and it really works and that really made me happy. Now, we'll look at the contextual model. This model was proposed in 2015 by Wormhold. The model tries to provide a framework for understanding how common factors facilitate change in psychotherapy. Common factors in psychotherapy are essentially the same concept as the factors highlighted within the contextual model of psychotherapy. So this contextual model explains how common factors operate to bring about therapeutic change through three pathways, emphasizing the importance of the real relationship between the therapist and the client. This is basically like the therapeutic relationship and alliance that allows a client to confide in the therapies, to allow clients to trust the therapies and to build a relationship, a therapeutic relationship with the therapist. Then he also talked about a second pathway, which is client expectations, and it's basically similar to the client expectations we have discussed before, that the fact that client is expecting a positive outcome in therapy helps them to get better. And then the last pathway he talked about was about the specific ingredients of a particular therapeutic approach. So in this pathway, he talks about the specific ingredient in the different modalities. For example, in CBT, he talks about cognitive restructuring. In psychodynamics, he talks about free association and how they work with therapeutic relationship, how they work with client expectation to bring about a change. So the most well studied common factors, which also are described within the contextual model, include the therapeutic alliance, therapist empathy, positive regards, genuineness, and client expectation. So basically, the conceptual model is just giving a framework because some people have tried to dismiss common factors, saying that they are atheoretical. So what the contextual model tries to do is to provide a theoretical framework and provide an explanation on how the common factors help and help to produce a positive outcome in psychotherapy. Conclusion. So, in this presentation, I have provided, or I try to provide, a foundation for understanding the essential elements of effective psychotherapy, and I highlighted the importance of integrating common factors into psychotherapy. So, these are the key takeaways that the therapeutic relationship is the strongest predictor of success in psychotherapy, and that there are client factors, and these client factors like motivation, social support are very important and crucial to progress in psychotherapy. I've also talked about expectation and placebo effect, and that they play a significant role in improvement in psychotherapy. I have also emphasized that the specific therapy skills and uniqueness and qualities in the therapies and flexibility enhance effectiveness in psychotherapy. References. Thank you for your time and attention.
Uh, Thank you very much, Dr. Esther, for the beautiful presentation. Prof, sir, you can continue, sir.
Yeah, thank you very much, Esther, for the beautiful presentation. I wish we were doing it very physically so we can clap and you hear the sound. Just those emojis of clap and thanks are not usually enough reinforcement. But thank you very much for a beautiful presentation, Esther. We really appreciate it. As is in our culture or custom, would be able to will have questions and discussions, so people will be able to make comments. Your comments, you can make comments, you can ask questions. You can choose to do it verbally by unmuting yourself and asking, or you can type it out in the chat. And that's how we do. So please, if you have any question, you can use your hands and ask, or you can type it out. It's not finished on such a good time, so we'll have ample time for discussion. So, are there any questions? Are there any comments? Both are welcome. And we have about 30 minutes or thereabout. Let's see. Yeah, we have about that. to look at the discussions together. Let's also, and for Esther too, it's important that we don't just discuss today. Other people would drop questions in the chat group for the whole week. So once in a while, just pop in there and see what questions there are and see how you can address them. And the questions will not just be for Esther, any participants, including the unknown participants. If you think we don't know your name and you're just sitting down quietly, we invite you to also make your own comments. And by the way, at the end of these sessions, the appraisal for each person would depend on participation. And the participation we mean is not just attendance, comments, questions, answers, and the rest are factored into the level of quality of participation. So we're open for comments and questions.
Sir, some people raise up their hand like Dr. Chibuzo Anoje.
Yeah. So please guide them into response.
Please,
Okay, like you mentioned, the person you just mentioned now can unmute himself and ask a question. Dr. Chibuzo.
okay, thank you, sir.
Dr. Diola, you can coordinate that, please.
Thank you, sir. Dr. Chibuzo, please kindly go ahead. Unmute yourself. Dr. Chibuzo, we cannot hear you, please. Kindly go ahead.
Oh, good afternoon, sirs.
Good
Good
afternoon.
afternoon, everyone. Sorry, it's a mistake. I didn't have a question. Sorry,
Oh,
I've lowered my
okay.
hand.
Thank you very much. Please, Dr. Ijarobe, please, ma, kindly go ahead.
Okay, good morning, everyone. Good morning, sirs and Mars. Thank you very much, Dr. Esther, for that presentation. So I just have some concern I want to express. So if a client actually discloses that she's doing certain activities that might be against the law, maybe criminal, and probably part of why she's in this distress is because of some of this criminal activities and her struggling to let go of some of the criminal activities. What would be the place of empathy um, in psychotherapy, or the place of advice? What would be the place? Is there any compulsion for the therapist to maybe disclose or report some of these things, especially if whatever this individual is doing is harming others? Let me give a frank example. Maybe this person is a kidnapper or is an organ harvester, and part of the distress he or she is going through now is that she's trying to leave, or he's trying to leave that organization, and the organization is making it impossible for him or her to leave. But by staying, she's going to continue to hurt other people, or maybe if she leaves, some other people like her family are also going to be hurt. What would be the place of empathy? How would one handle empathy in the context um resolving this in itself is going to bring maybe pain, suffering, and hurt to a lot of other people? Thank you.
Thank you very much, ma.
Okay,
Dr. Esther, if you want to go on this or you want some people to ask more questions, then you can answer, then we'll continue the circle. Or what do you?
okay. People can ask more questions.
Okay, thank you very much. Please, Dr. Ubong, kindly go ahead with your. I know you sent a comment, but it would be nice if you unmute yourself and ask the question.
How do I unmute myself? Am I heard?
Yeah, we can hear you. Please, kindly go ahead.
Okay, so my question is, What's thank you for your presentation. What's your take on your client, your patient having adequate ego strength as a requirement for psychotherapy? I don't know what's your take on that.
Uh, Thank you very
That's my
much.
question.
Noted. But I will also play that so we ask some question might be general, but we will prefer if it's more focused on today's presentation. But there are, of course, there are, our teachers are here, and everybody have will all contribute towards this. Thank you very much. There is someone.
Sorry, Dr. Abiola.
Yes, sir.
Dr. Abiola, please let Esther take these first two questions,
Okay.
especially the first question because it's relevant. It's on today. But the two questions that have been asked of us, I think you should check them because the first one, for example, may be a very interesting thing to discuss about. So maybe we should take them. Then after that, we can get the other questions.
Okay.
Uh,
Thank you very
other
much.
questions.
Yes.
Yes. Okay.
Please, Dr. Esther.
Okay. Thank you. Thank you, Prof. Thank you, Dr. Is very vital and is a challenging one. But I know that there are statutory limitations to confidentiality. I'm not talking about empathy. So if a client comes to you and confesses he has done some criminal act and he really wants to change, of course, we still show some empathy. But if the client is going to continue in such an act and is going to continue to harm people, his privileges for confidentiality, I believe, will have to end. So I don't know, but I think other people should contribute to this, but it's a tough one.
Please, can you also say something about the second question about on ego strength?
Okay. Around that, but I think the ego strength of the individual will definitely contribute to outcome in psychotherapy. It helps people to cope better with stress, with adversity and setback. So definitely it should be a client factor that will help to improve the outcome of psychotherapy.
Thank you very much, ma. I'm sure more people want to ask questions, but as time goes on, we all will make comments, please. And for people that have questions, if they want to also share more on their question, please, it's open to all of us. Uh,
Yeah. Uncle Taju,
yes, Prof, sir.
are you hearing me?
Yes, we can hear you, sir. Please go ahead, sir.
Yeah, may I just add something? This is after we praise Esther for her presentation. Just that point about empathy and breaking the law. Please, empathy is not the same as being sentimental. Being empathetic does not in any way entitle anybody to aid and abet breaking of the law. What we should do is to appraise ourselves with the provisions of the law about such disclosures and follow those provisions, because if the law enforcement agencies come into the show, they are going to follow the law. They are not going to listen to your entreaties about empathy. It is ignorance is not an excuse. I think a therapist who comes across such issues should go and appraise themselves with the elements of the law on that matter. I don't exactly know what the elements of the law are, but there should be a provision about who is more important. Is it saving the individual's skin or protecting the society? My but please, let's appraise ourselves, especially a therapist who comes in contact with such experience should appraise themselves and probably um, get a lawyer to get an opinion. Because I repeat myself, ignorance or empathy is not an excuse in the eyes of the law. Thank you.
Thank you very much, Sir Prof. Maybe just to add to that, that these are areas that also border on ethics, and hopefully along the line there will be some sessions on ethics of psychotherapy, hoping that this will be also further clarifies it. Thank you very much, Prof. Uh,
Sorry,
Okay, I just
Tajudeen,
wanted to add something too. Thank you, Prof, for that. That is very important. Thank you, sir. And if you remember the, is it Torasov versus Ponder in forensic psychiatry in the US, they had ruled, I don't know how applicable, that is why what Prof said is very important. We need to study the law to know what is applicable here. And I know they eventually ruled that the privileges for confidentiality ends when a third party is threatened. That is for the US. I don't know if it's applicable in Nigeria, but it's something we need to look at. Thank you.
Thank you.
maybe I just let me just make a quick cut and assure everybody that before we finish this series of lectures, we'll get a lawyer who he understands medical practice to bring to come into the group and give us a lead a discussion on this. I think that probably will be the best thing to offer. Maybe that day we open it up to all the other. That day we open it up to all the other psychiatrists who would like to listen to the legal aspects or the legal restrictions or confines or latitude of therapeutic relationship. Because this is not just about breaking the law. All therapeutic relationships even if you're not doing psychotherapy, we all have relationships with our patients and there may be issues. So we'll get someone to educate us better on that. Thank you very much, Grace, for raising this whole thing. Thank you.
Thank you very much.
May I add? May I add, sir, if you don't mind, that it's nice of you to look for such a lawyer,
Thank you, sir.
but please, such a lawyer, I suggest, cannot exist in Calabar because Calabar is a place of rest. People don't kidnap or do terrible things in Calabar.
No,
So
Calabar is a heaven. We don't have such things. I agree with you,
yeah,
Jude.
that's exactly what I mean. You shouldn't waste time. You should go to
We're not hearing you again, Jude.
Maybe network challenge. While we wait for Prof to join us again, sir, if we may call on other people that have raised up their hand uh, to ask their question, please. It would be nice if you talk than to type, but we'll still be able to take those that type. But people that want to talk, maybe they should talk first. There is somebody, fellow Gistas. Uh, I don't. His name was not clearly written, so I don't know whom the person is. But the person raised up with their hand much earlier. If the person can go ahead, maybe while we wait for that person, as also there is the Dr. Jennifer.
Abuja to look for such lawyers.
Okay, Prof, you are welcome back. We could not hear you for most of your other part of the comment. If you can retake your comment, please, sir, about where to get such a legal mind to talk to us on this issue. Thank you, sir. Okay, while Prof is still trying to rejoin, please, Dr. Jennifer, kindly
Hello,
omit
sir.
yourself.
Can you hear me?
Yeah, we can hear you. Go ahead.
Okay. I want to thank my teacher for the great presentation. I want to find out if there's any barrier to the therapist discontinuing therapy with the client. I will give an instance. For example, if there's a form of sexual attraction towards your client, would you discontinue therapy? And if that's yes, are there other conditions or barrier to continuing therapy with a patient? Thank you.
Thank you very much. If Dr. Esther want to address
Dr.
it.
Jennifer, I didn't hear you. I was disconnected. Sorry, why?
Okay, please, Dr. Jennifer, can you retake your question, please?
Okay, ma, I said if there's any barrier to discontinuing psychotherapy with a client. So I gave an instance that if the therapist perceives some form of sexual attraction towards the client, is the therapist free to discontinue therapy at the detriment of the client? And if yes, are there other conditions, situation where the therapist should discontinue therapy and maybe pass it over to someone else?
Okay. Thank you. Dr. Esther, I think you get the question. Maybe if I may add, or please answer the question. Thank you. Dr. Esther, are you there? While we wait for Dr. Esther to rejoin us, so that we please kindly unmute yourself, Dr. Esther, so that you can. While we wait for that, maybe one of the time we bring forward, hopefully that maybe a future lecture will also address is the concept of erotic transference. The similar thing, what you are describing might also fall into what's called erotic counter transference. And I'm sure our teachers here will help us address it better. But this is just to give us the concept that we can go and read after this, so that we can take more comment from people, because these areas help to address these issues, how the therapy should be able to do it. But I also want to add that supervision in psychotherapy will teach the budding psychotherapists how to handle such gray areas, which is one of the reasons why supervision is very essential. So, but this border on those erotic transference and erotic counter transference, and supervision usually help to address this. This is just the brief I have on that. I hope others might contribute more on this. Uh, while we wait for more contributions, if I may also plead with our elders that are here to please talk, I may ask Dr. Adelodo Emmanuel, who typed a question here, if he wants to speak, so that we, but if it's not, if I may read the question so that it can be addressed. Please, what strategies can be used to work with clients that's persuaded or forced to undergo therapy? I don't know if we heard the question.
Am I still on the line?
You're welcome back, sir. You're on the line, sir.
Yeah,
Now,
somebody called me and cut me off. So now, what I mean is, you tell these people about realistic expectations, so that in short, that's what I'm saying. You don't allow people to say because this is a big professor or whatever treating them, they are going to be okay. No, it's to let them know that there is a disease signature even when you are doing somebody's psychotherapy. And let's say with depression, you have to say that this psychotherapy is an adjunct to treatment, depending on the type of psychotherapy. If, for instance, they have severe depression, it's not that the psychotherapy him alone and is all right. No, he needs his medication. So you're not going to say because you therapied him, then he's not going to be taking his medication. It's not true. Psychotherapy at whatever level remains an adjunct to treatment. So finally, what I tell these people is that the fact that I'm able to get you well, whether by therapy or drug, shows that what you're suffering is not a spiritual attack. Because I mean, most patients who come to you this in this country anyway, they say they have spiritual attack. I say no problem, because spiritual attack is more like a cliche. It's a language that our people are using for either things that baffle them, or it's their own defense mechanism about what is happening to them so that they will not claim responsibility, whatever purpose that cliche serves. You tell them, see, I'm not a spirit or a juju man. I'm able to get him well because I have a level of understanding. And the point of the concept is I give him medication or I talk to him in ways that take into consideration what I think are the theological factors, and he gets as well as he is. So please stop this spirit attack or spiritual problem thing, and let's make sure we keep to the rules of how I got him well. Okay, thank you.
Thank you very much, sir. There was also a question on erotic cattle transference. That if a client is in therapy and the therapist is sexually or romantically attracted to the client, the question is, what should the therapist do about it? If there may be a comment on that.
Let Esther should be better at answering that. Esther, can you go on? Let's hear you talking. You know, there's a case like that in the Senate, and we don't know who is winning yet. Or does anybody on this forum know who is winning the battle in the Senate? Do we know as yet?
No, sir. No, sir.
Do
Well,
we
sir,
know what is happening? All we know is that one person has been temporarily nominated, she's going to be disclosure. I'm actually rooting for her. First of all, she's a very beautiful Ukrainian girl, and I like Ukrainians. Did you know that her mother is Ukrainian? She's a very
Yes, sir.
pretty girl, and I think she's prettier than all the girls I've seen from Akwa Ibom. And I'm hoping that Owedo is not listening here. I think he's been knocked out, so I can
No,
see any.
he's not listening. He's not.
Okay.
He's not listening.
Yes. So I'm rooting for her. But jokes apart, please let's hear you, Esther.
okay, thank you, sir. First of all, I think it's unprofessional, although it's of course, and it can affect the therapeutic relationship. So it is important for the therapist to set professional boundary when conducting psychotherapy with clients. I've read a lot of cases like that in Western countries where doctors perhaps lose their licenses for having such unprofessional relationship with their clients. So if that occurs, I don't know, but my advice, personal advice is that the therapist may need to withdraw from that relationship and if possible, may hand over the client to a colleague or another therapist.
Okay, my
Thank you,
take
Maybe
sir.
I
on it,
should.
my take
Can
on
I?
Thank
my
yes.
take on it is, yeah, just a moment. My take on it is as follows. Number one, it is the fault of God. God inserted this sexual element into beings, and it doesn't matter. It's not just human, ants, bees, everybody is doing sex. Sex is the most popular, most common activity for organic beings. I don't know about inorganic beings. So it's a fault of God. And if anybody can get to him, we tell him, please, sir, this thing, it has killed us. Find a way of helping us out of it. Create some other kind of relationship between human beings or beings. Okay, that's serious. So, number two is the psychoanalysts have taught us about transference and counter-transference. This is a dictum in psychiatry. I remember my boss, Olatawura, whom I model myself after in psychotherapy and psychopathology. If you went to his office those days, did you know, at the back of his door, or that's if you're inside, he wrote it clearly. Transference is allowed. It will always happen, but counter transference is not allowed. So, how did the old school do it? Like I was trained in Southampton, you have a period when you go through yourself, master your own impulses. There will always be attraction between human beings who are healthy. You can't say because you're attracted or there's food in front of you, then you go and grab it. No, it helps you to grow. If you have a feeling of sexual feeling with your client, that's not evil. That's not even bad. It shows your life, but go and deal with yourself. Go and grow up or overcome it, and that way you grow. So it's not to give an excuse. It's not an excuse at all. But the dictum stands. Transference is allowed. There will always be a situation where you impress a client and they are horny over you, but you are not allowed at all to reply to that. You are supposed to deal with it in an adult manner, and that manner depends on your own level of evolution, how much you are matured and how you are going to do it. It all depends whether you withdraw, whether you talk to the patient about it. These are very intimate and situation specific things. But the point is not to allow it to go on like that. If it gets too much, you should report, you know, transfer the patient or whatever. But counter transference is not allowed. Thank you.
Thank you very much, sir. So the erotic counter transference has been cleared for us, and thank you for making that clear. Professor Dufia, you want to make a comment then? If you still
Yes, I wanted to say that 99% of the things I wanted to mention, you do that already. The only thing left that maybe I should even say also is that the patient has gone to see a doctor or a therapist. You are the therapist. If you have your own problem, look for your own therapist. What I'm trying to say is, if you have issues with handling such a thing, you need therapy yourself. So, like Judah said, if you can't handle it, come clean, get out of the situation and let the patient see another. Because it's so sad for a patient to be traumatized in such a situation before coming to see you. And in that situation, you are going to traumatize the patient. So if you need help, like Jude said, people are encouraged to assess themselves. I can't remember the phrase now. Self psychoanalyze yourself, get analyzed. If you can't analyze yourself, get help. And it's funny because some people tend to fall into the same liking for the same set of people. If you know this type of person is what causes you problem from start, if you can't help it, don't accept clients who are like that. You can know that people who have broken legs always break your heart. Sorry, people who have broken legs are in your specs. So when you see a patient who fits that spec would cause you trouble, don't accept that patient. Therapeutic relationship is a social relationship. So all the troubles you've had in other social relationships, the possibility of bringing them into a therapeutic relationship exists. And in one, counter transference is not accepted in any way. If you have weakness to a certain type of group of people, get help. Psychoanalyze yourself, get help. If you have difficulty in containing in such situations, don't take up clients who fit that spec. I think that's just the core thing I can add in this other way. But I think Jude said most of the things that is there to be said on it.
thank you very much, sir. Professor Ahmad, if you want to make comments. But as you are waiting for your comments, some people also want to participate. Please kindly unmute yourself and talk, please. While we wait for people who want to participate to talk, to unmute themselves and talk, there is also a question here, Dr. Esther, that it was typed from Dr. Emmanuel. He said, please, what strategies can be used to work with client that's persuaded or forced to undergo therapy?
Okay, it will probably depend on the setting. For example, if a client does not have insight, does not even know why he should be in therapy, you will first of all want to do a motivational interview to see if you can get the
There seems to be a technical glitch. Please, Dr. Esther, kindly check your network if you can still hear us. Sorry, Dr. Esther, we can't hear you.
phone to some of these on the platform, the WhatsApp platform.
Okay, thank you. We just hear your last word, Dr. Esther, about the WhatsApp platform. Maybe if
Okay, I was saying because I'll be having issues.
okay, the network issue is back again. But I want to believe we get a comment and a review of it. That if I may put it in another way, there is a responsibility of the therapist to be able to ensure if the client needs therapy and to ensure to practice his or her skill to see that the person is motivated enough to participate in the therapeutic session. And she started with the motivational interviewing and other techniques that are needed there, which will play a big role and a long way to help people who are in therapy, or to help people who are there but needs to be helped to get into therapy and to benefit from the therapeutic session. I, I know a lot of us are still here. Please, our comments are needed. More questions. We still have some few minutes to go.
Okay. Good afternoon, sir. Good afternoon, everyone in the house.
Please kindly go ahead.
Thank
Good
you.
afternoon.
Thank you, Professor Mrs. Okogbeni, for the lectures. Please, mine is a request and a question. Is there a possibility of us getting the slide that was presented? That's one. And my and second one is there contraindication to psychotherapy?
Okay, thank you for the comment and the question. Dr. Okogbeni, if you are still there, uh, I think it's part of the tradition to make sure that the slides are available after the session, and we'll discuss with her to see towards to that end. And if there are contraindications to psychotherapy, yeah, there might be contraindications to psychotherapy, but it's not a it's not a fixed rule. Just like every treatment, there may be contraindication to any treatment at all that somebody might be that might be indicated in somebody. So it depends on the expertise of what is available, the challenges or the problem or illness or condition that the patient or the client is coming with, that may all work together to guide whether such a therapy might be useful or not for such individual. So all this work together to determine whether somebody might benefit or not from participating in the therapeutic session. So it is part of the training of a psychotherapist to be able to pick that, to see that, so that this individual can fully engage in it. For instance, somebody who is psychotic, frankly psychotic, it may, and the person cannot be engaged, then it might be challenging to put that individual into therapy. Yes, there are some therapy for psychosis, yes, but there must be some level of engagement for that individual to be able to participate and benefit from such. So there may be some reasons and some conditions and some situation that may warrant that. So all these, so they are not something that I can say this is just a general rule, but as the individual practice and continue to be under supervision, continue to participate in peer supervision, even if somebody is an expert therapist, there will continue to be supervision also, peer supervision, and the individual to have his own therapist so that he may encounter so many challenges that he will need to also process in his own therapeutic session in order to be able to be of best help to his or our own clients and do that effectively. While we wait for more comments and addition, I also want to bring one thing forward in the presentation that was given to us beautifully by Professor Esther Kubini. And that thing is about the client that had a single session and got well, which means that there is the concept called the single session psychotherapy, and that is was practiced expertly there, and that individual got well. So that a session might solve some people problem, while more session might be needed, and it depends on the expertise and the understanding of the therapist who will be able to get to that. Single session therapy might all in this process will also bring to the fore for one to know that this individual might need more or might need not. So, and that's why carry out therapy, especially at the expert level, the individual will be able to know what this individual need and be able to do it well enough. And that is why today's lecture, which is on common factor, is saying that there are many other factors there, but the experts' participation is also very, very important, because the performance at the expert level will be different from somebody who's at the intermediate level or someone who is at the body level. So all these are very important for how engagement in psychotherapy will play out and what the outcome we might see. I hope that what is learned today will be able to to get engaged with it and continue and also make more comment on it on the WhatsApp page as we discuss further. Uh, I can't close the session because there is still time, and I wait for more of our contributions while we wait for our prof to guide us more to move forward in this. Thank you very much.
Is there any, I think there's still a hand up. Dr. Temi
Tayo,
Toya.
Tayo
Yes.
Ijarogbe, please unmute yourself. Dr. Ijarogbe.
Okay. Sorry, I thought we didn't have enough time, so I just penned down. I just stepped out this particular question that I had. So for those of us that work with young people, sometimes we meet individuals who are chronologically adults, but in terms of mental age, are children. So someone that's like a mental age of 80 years. But in some of these our communities, their parents want them to get married. They want them to continue the family line. They are ready to support them in whatever way that they want. Um, that is required so that they can have. They just want that lineage, and so some of these individuals are actually packaged into marriage, where sometimes the partner is not even fully aware that, because I mean the person with intellectual disability just looks as beautiful as the next person. may not be fully aware that this individual um, is not fully cognitively competent. Now, if in psychotherapy one had to engage an individual that um, has some form of impairment, is that even feasible? Would one consider such an individual as a viable client for psychotherapy? Or is there a way one can categorize it, whether okay we can engage this person or not? Or does one just clear disclose that, oh look, this person has intellectual disability, there's no way this can be done? How does one negotiate that kind of situation? And sometimes the family insists they don't want the some packaging at the initial outset of that marriage. Thank you. I'm sorry, I'm just bringing to for some of the challenges that one has come across in the past that one could not resolve using this opportunity. I'm not even sure if I was so clear.
No, you are very clear, ma. We can hear you
Oh,
clearly.
okay.
Yes, and I'm sure
Okay.
everybody here had your question and they can effectively engage and participate.
So should one just have declared this is not a viable option for psychotherapy, or should one still try to do something or see whether something will work?
Grace, thanks a lot for. I think you are so experienced in this matter and children more than many of us here, and we really appreciate your presence. But my point is, you've just said the family wants something. The the adult who is involved is a child in his mind, which is an interesting thing. Uh, So what that is the my assumption is that the patient, your client, is having a problem because of that. And
Yes, sir.
yes, I understand that. That's actually why it's coming on. But the other way, let me extend your question. What if the partner, well, the partner cannot be an underage also? So let's leave that out for now. So I don't know how it's going to. Okay, even if the patient is underaged, the parents still have responsibility, right? Because he's underaged, and sometimes it is not to propagate the family name; it is to get a stable support for the person when the parents have died. That's also a
Oh,
possibility. Sorry,
that's true, sir. That's true.
that
I
so
say, yeah,
so
wow.
so if that is the case, in Nigeria we don't have any social support system. So that is the only social support system the parents are thinking about creating for the child, for the let's just call child for the client.
Sure.
And I think I don't know. I think the only part I think a psychiatrist or a therapist should play is to let the parents know that the spouse they are arranging for should know and accept. I think that's just the core thing. You understand? Because I think I didn't hear that part well. Maybe sometimes you don't want the spouse or the other partner to know this person is not adult enough in quotes. I think that's the part that is unfair. I think that the other partner should know that this person has such limitations. Because even if he doesn't or she doesn't know that such limitations, if she finds out or he finds out later on, that relationship, let's call it marriage, is not going to be valid because
Mm.
you can't go into such a contractual arrangement with someone who is not able to understand. So anytime the person finds out, if the person wants to leave the relationship, the person will be legally free to leave the relationship. So I think that it's the legitimate support for the child, for the child. But I think our responsibility should be to make sure that the spouse or the other partner, whatever I want to call the person, is aware of these limitations and still wants to participate in it. I think that's how I'm seeing that. I may be biased in the answering of the question, but I think that's a fair and right way psychiatrists and therapists should ethically consider that sort of thing. I don't know. That's my whole answer for that.
Thank you very much, sir. Just based on what you have said, it's brought it more simpler for us that to see it more in this, so just to see that this is a case of a minor and a vulnerable minor, not just a minor, maybe a vulnerable minor. The way it's presented. So if the person should have a mental health challenge, which make the person to bed, and also be a minor, those are two dilemmas to deal with. But irrespective, that even if somebody who is with vulnerability is brought and is a minor, there of course there are some therapy that may be indicated in them, maybe like art therapy, play therapy, because you talk of the child adolescent, and that may help to bring forth what might be the background mental health challenges if is present, and so that that can help to get the basis to help this individual to participate, because both what is happening, the play therapy, the art therapy that is happening, will serve both as to help to bring forward what might be the background condition or psychopathology that is there, and will also help in carry out the therapy for the individual to be able to achieve some level of healing through the process. And that supports what our teacher have said. And I don't know if this contributes in any way to your question mark. But also on this, somebody was asking that I don't understand. I think anyone who requires psychotherapy actually has some form of mental illness, ab initio, or are you talking about psychosis? So I really don't know the context of the question, but probably maybe the presenter might understand the context of the question based on the presentation and be able to address this question. And this is from DDNS Bambade Adukule. Thank you, ma.
Okay, so I could shed a little more light. There are expectations of very beautiful lady, very beautiful, but she can function barely minimally. She can do chores, she can do little things. The husband, the family they are not able to understand certain things that somebody else. She looks normal. Why is she not meeting certain expectations that they believe is required of an adult, a responsible adult within marriage? And so these are something that have now created issues. The couple are ready to, the other partner, all of them are ready to, happy, let's see what this. But there's something the other family are hiding. They're not ready to divulge and all of that. So I take it away what you just said now, sir, about maybe using other forms of therapy for that are maybe more age appropriate, mentally age appropriate for that individual. But I don't know. It's so tough. It's very difficult. Thank you. I'm taking notes, sir. Thank you.
Prof, sir.
Yeah, I think it's our time is well spent, and we thank Esther for starting it all by bringing us an interesting lecture that led to this discussion. And we must thank Grace for her presence and bring these practical things. And Tajudin, I think we should rewrite the question, because in the recording that we have, I don't think these questions are going to be there. So I think we should ask especially Grace, we should ask her to do the question in a written form so that it will be available in the chat group. so that other people who were not present to listen to it can see the questions and make comments. We may eventually have a richer and more complete discussion on it. I don't know if you get the point, Tajuddin. I
Yes,
think the
sir.
question should be rewritten and let Grace approve the form the way it is written. Then it is put in the post. Sorry, put also in the platform so that people who are joining would see the question and make their own contributions to answering them. Yeah. So
Noted.
thank you very much. Yeah. Yes. Thank. So I thank
No,
everybody who is present. I can't see the number.
Sorry, sir.
Joe. Okay.
Sorry, sir. I'm just wondering, Professor Ahmed Garba from Canada, why is he not commenting? We will be enriched by his comments. He's,
It's
I
available.
think it's on the platform, but it's not
Yeah, maybe maybe the
making a
time is
contribution.
not perfect for
Is he
him.
hearing us?
We don't know where exactly he is at.
Yeah, but it's on the.
Well,
What I mean is that he's showing
all
is on
right.
the
We would
platform.
ask him after the class what has
Does that
happened.
not?
Let's talk with him after. Then we understand what it is because it may be difficult to get him immediately now and let him respond to it. Jude, I
Immediately
think we'll
we
do that
draft it.
and contact him and
Okay, um, yeah, with respect to Grace's question, may I just pose a moral issue? Is it really fair, knowing that this person is schizophrenic or whatever, and then you get a nice girl, young girl, to come and marry her, and she agrees, maybe because of her circumstance, and knowing that the family is going to be married to okay, I mean, is it in your experience, people, that girls, for instance, who are married, because girls are more vulnerable, they are more in trouble, boys can walk away. Is it in your experience that these marriages do well? Is it in your experience that the girls are not thereby tortured, especially if the man is, let's say, treatment resistant and is not doing well, and so on and so forth? Is it fair to subject a fellow human being, a daughter of somebody, to this lifelong stress? Should we be encouraging relatives to be thinking in that way? And blah, blah, blah. In my experience, it's not fair. I've not found it useful. Um, in many occasions, in a rare number of cases, it has been okay. But that's because the girl insisted and the man is manageable. But if the man continues to hear voices and is not doing well, and he has, let's say, negative symptoms, is it fair? Actually, I think 3 or 4 days ago, I was involved in a family meeting online with these families, and one of the sisters of the man was asking, he said, "Doctor, are you sure the medication you are giving is not going to affect his manhood?" And the mother was there. Oh. Their mother was in the call, and two other sisters, and the man. And how they beat up this fellow for beating up the girl and told him, "Don't do it again." Anyway, my frustration is high on this matter. I'm worried about the moral and so on and so forth. so forth.
Sorry, sir. Network challenge. We we can't hear you clearly, sir.
Okay, I think we should. We get the point. Grace, I don't know if you are still there. Are you still up and you are still hearing? We've heard what
Yeah,
Jude is saying,
I can hear you, sir.
but yeah, what I'm thinking is that, like I said in my own comment, the family, the individual who is well, has to deliberately accept, understand, ask questions, get answers, and get into it deliberately. Not that he should be deceived into it. That's actually what I think. That the person has to understand and ask questions and everything and agrees to go into a relationship. I think that's the only thing that we can do. Because usually, because of money and other things, it's difficult for the person to really understand and take decisions. But the core thing is nothing that should be known, that everything should be disclosed. That's actually where I think that everything should be disclosed from start so that the person is doing an informed consent into it, not to be deceived into a relationship. And yeah, I think that's the only comment I'll make to what Judas, to moderate what Judas said. Gentlemen, we would write these questions out properly and would let it be in the chat group. So this discussion will continue. We've gone through the period we're supposed to. We've actually 17 minutes beyond the time. And we thank everybody who has been glued in and stayed throughout the discussion. Would write the questions down and the chat discussions would continue. So more questions can still come, more answers will still come while we wait for the rest of the week. So, Tajudin, please, you can end us now. Thank you very much, and thank you for everybody coming. Grace, thank you again for your questions. And Esther, you've been
Sir.
a darling again. Thank you very much.
Thank
Thank
you
you,
very
sir.
much, sir. Thank you, Dr. Esther.
Thank you.
Thank you, everyone.
Okay.
Yeah, thanks.
Thank you, Professor.